Hello, my name is Kevin Williams, and we're going to continue our conversation with managing the non-motor symptoms of Huntington's disease. Our co-presenter will also be that of Dr. Sung, who we've been learning from together. And we're going to now move into a conversation with our patient and care partner regarding the impact of psychiatric and cognitive symptoms of Huntington's disease on their family and on life.
All right, for this next section, we're joined again by Mr. and Mrs. Duggar. Thank you again for joining us.
You're welcome.
This section will be talking about a deeper dive into the psychiatric and the cognitive symptoms of HD. Let's start with the psychiatric or the behavioral symptoms. Have you had any depression or anxiety that comes with the disease, and how do you feel like you've managed that over time?
I have had a lot of anxiety, and I've had to reduce my responsibilities quite a bit. I used to have a bunch of antique cars, and I sold all of them. So now I don't have all those to worry about.
Yeah, I remember the antique cars and the different parts, and was a strong source of anxiety for you. You know, what part is coming on eBay and what part, is still left out there to find, to put it together. And as you kind of put that project away, how do you feel like that has helped or not helped with your anxiety over time?
It has helped tremendously with my anxiety. No, nothing to worry about. I wish I had sold it years ago.
Yeah, it's interesting. Some people can find that hobbies are an outlet for anxiety, but then sometimes when it's complicated things like putting together a classic car, it can be a source of anxiety and maybe drive things to make them worse and not better.
Right.
Okay. So, Sheila, how do you feel like things changed when Tom sold the car, and how things changed from a depression anxiety standpoint?
Well, we kind of miss them, to be honest with you. It was kind of a love that we had for them because we were always searching for parts and, parts you can't find. So, but when he finally made that decision, he was ready to let them go. He was ready to let them go. And so then we were ready for the guys to come get him because I didn't want him to look at them then. It was just kind of like a kid with a new toy at Christmas and you're like, don't touch that toy right now, Yeah. So, yeah, but
Okay.
it's better now.
Okay. And then related to kind of depression, anxiety, what about impulsivity or impulse control problems or obsessive compulsive types of tendencies? There are certain things in the way that that's weaved into anxiety, but have you had any of those things or observed any of those things, and how have those done over time?
I don't think I have those behaviors. I just don't. I can't recall any time.
Okay.
Impulsive behavior.
Okay, that's good. What about thinking and memory problems that you've noticed with HD and how those have impacted your life?
I think I might have a little bit of memory problem, but as far as my thinking goes, my cognitive part, I don't think I have any loss of cognitive part.
He's actually, I think he's still sharp. I mean, he pays our bills online. We actually went on 2 really nice trips. He booked all of our reservations, airline tickets, rental cars, all our hotels, all those kind of things himself online. He did all that. I mean, as far as like movies, we watch a lot of movies on Prime. I mean, he has to control the movies because I can't work the control. I don't even know how to work the remote control. And so, yeah, I think he's still pretty sharp.
Okay, that's great. And that's, I think, important to make a note of, that not all patients with HD develop dementia early or even, we're a number of years into the disease, and you're still active and doing a lot of things in your life. A lot of that, I think, owes to you guys being proactive, staying active, both physically and mentally. So tell me a little bit about some of the things that you do on a day-to-day basis that are kind of physical activities, mental activities to keep your body and your mind sharp.
Tom reads a lot, and he loves Facebook. He goes to eat with his friends. He goes to eat lunch with his friends about once a week.
Wow.
He's still in two of the car clubs that we've been in for years, and we have monthly meetings with those friends. So we kind of stay in touch with friends. And
I met a guy who books a million every Tuesday and have coffee with him. He's a guy from Tennessee, pretty good guy.
So staying mentally engaged with your reading, staying socially engaged by still going out of the house and meeting with friends, having good conversation, things like that. I think those are all great things to kind of keep your mind sharp. When you're meeting with friends, like for coffee and things like that, do you ever find that you have more difficulty remembering what time or what place you're meeting, or it's part of the routine now and it's pretty well established?
I don't think I have any trouble at all.
no, and they don't go to lunch at the same place. His friend he goes to lunch with, they go in different places. Sometimes he'll come by and pick up Tom, but most of the time Tom meets him. So he still drives, and he's a good driver, Tom is. So I worry, of course, but no, they go to different places, and he's always early. He's never late. So yeah, there's no issues there.
Okay. I think that's great. For some people, the cognitive and psychiatric symptoms can be earlier than the physical symptoms and can dominate. But I think you guys are a good example of it doesn't have to. It's not like all patients with HD are going to develop full-blown dementia. So I think that's good to see someone in their 60s with HD still kicking it and fighting it strong, like we talked about earlier, and fighting it with everything that you guys have and are staying active.
Definitely.
Yes, sir. Definitely.
Now that we've understood and really appreciated the impact of psychiatric and cognitive symptoms on our patients and their families, I want to kind of move through how do we manage some of those non-motor symptoms of Huntington's disease. So when we really begin to look at how we manage the depressive symptoms of Huntington's disease, it's important that we understand that it can manifest years prior to the motor onset of the disease, and really ensuring patients have that extra social support around the key times of peak moments of depression in Huntington's disease through the course of their life is real important, considering that of genetic testing, getting those results, who are we going to disclose those results to, obtaining the initial diagnosis, when does the symptoms onset, patients having loss of work, loss of independence. These things can really become those peak moments when our patients need the most support. And as providers, as community, it's real important that we surround those patients during those moments and really help carry them through the progression of the disease. Not only are those key moments important, but really depression begins to compound as the patient begins to have loss of self, loss of friends, their abilities to do things, and then their ability also to work. So it's important, and we'll talk in just a few moments about psychotherapy and how patients specifically with Huntington's disease can obtain psychotherapy. But there is still an importance. I really want to make this key point here, that there's an importance and benefit of patients undergoing psychotherapy. I've had some conversations with psychotherapists that were like, well, as their condition progresses and memory and agitation progresses, I'm not really sure the benefit that they have. Well, I'm one to have the belief that even as the condition progresses, having a form of psychotherapy that's not just for the patient, but also for family and the approaches, and ensuring that staffing and caregivers really understand during the progression of the disease, on how we can assist the patient, is vital to the prognosis and the treatment of managing those depressive symptoms. We've shared and talked about how suicidality and suicide ideation is so important, and particularly the high risk in the Huntington's disease population. But now I want to spend some time really going through how we can prevent the suicide in prevention of suicide in Huntington's disease. One, it's important that we have early acknowledgement and then have regular assessment, that it's not just once and done, but that we should really ensure that the patients are getting regular assessments through the duration of the condition. And we have tools like the Columbia Suicide Severity Rating Scale that can be utilized. We can embed those things into our EMRs to ensure that it's easy accessible to our staff and to providers to assess the patients. And the next thing is really having crisis prevention and utilizing that team-based care. We also have some mobile crisis teams in areas of the country that really begin to help in our communities to provide that mobile assistance. But as Dr. Sung mentioned in our prior presentation, really utilizing that team-based care and not passing that buck off to the next person, or talk about that with psychiatry or talk about that with the neurologist. We really should have that team-based care that ensures not only is the neurology team and the psychiatry team and the patient's caregiver understanding that risk, but we communicate together to ensure that we're preventing any risks of suicide. And then we can treat with having a safety, which is that safety protocol and telephone follow-up, and really incorporating that, that we're ensuring that there's protocol that's also discussed with family, that it's not just that we're doing it in the office or doing it in whatever facility we're in, but that the families and the caregivers also understand how and where we have the safety protocol for home and in our communities, and then having that telephone follow-up. And in the Center of Excellence, we have those capabilities, but also for individuals in our private practices who were not associated with the Center of Excellence, also ensuring that we understand that risk and have the staffing available for the telephone follow-up is also important. So when we're attempting to manage aggression and irritability in HD, it's real key, as you're kind of seeing as we're discussing these non-motor symptoms, that in Huntington's disease, it's not just about the loss of cognition that's common in conditions like Alzheimer's or in dementia, but really patients with Huntington's disease carry and experience several other non-motor symptoms. One of these is aggression and irritability. And in my experience, this is generally one of those aspects that draws families to talk about their inability to care for their loved one at home, and begins to transition them into that long-term care space where we begin to manage some of those things. But ensuring that we are educating our families and in educating our patients, that we should really ensure that we're managing the environment of our patients. What do you mean by managing the environment? I'm glad you asked. Well, assisting with reducing the triggers. But what are the triggers? We have to really pause in our treatment, and not just, well, they're aggressive. Well, what does that mean? What does it mean? What time of the day? And really doing a broad assessment so that we can result in reduction of triggers. So they may be relatively trivial, and if we're not spending that time of pausing and getting down to the foundation of what those triggers potentially are, we will miss those trivial things at times. It might be physical or emotional discomforts that our patients are having. And I also like for us to really talk with caregivers and family members and even staff we really have to choose our battles. Do we really need to go back and forth with the patient? Is there a need for us to correct their statements, and really choosing how we want to interact to help reduce those potential triggers that our patients can experience? And this is where it's very vital for us, when we are experiencing patients with aggression and irritability, for us to refer them and the family to psychotherapy. Now, I'm going to say this: it's important that the patient and or the family gets referred to psychotherapy. I found when family and patient are able to work together with psychotherapy and the psychotherapist, it really helps bridging some of the gaps to help reduce some of those triggers that our patients experience. Not only we talked about aggression, but next also the impulsivity and some of those obsessive compulsive tendencies that our patients have. I'm going to speak more of impulsivity now. We need to have our patients with decreased filters. With them having the decreased filter, these patients can have some social stigmas. Oftentimes, it can lead to legal troubles. So we should try to anticipate those areas of difficulty. And because there is some issues with remorse, oftentimes they'll have immediate remorse. So really ensuring that we're extending the grace, forgiveness, ensuring as we're working with patients in the community, recognizing their decreased filters will help to reduce some of those issues of impulsivity. Now, when we're really dealing with some of those obsessive compulsive behaviors, understand that may not be forgetfulness, and when needed, we should redirect gently when we're able to do that. And this is an area that I really try to help families and staff members in facilities, is that we have to redirect with grace, redirect with a gentle hand when we're able to assist with some of those obsessive and compulsive tendencies that our patients can have. Writing answers to most commonly asked questions on a board, on the calendar, it helps for the patient to be able to reference that. We can go back through that and not in this aggressive tone, like it's on the board, go read it, but redirecting them back to the board. Let's review this again together, ensuring that our patients are able to be reminded with some of those frequently asked questions, obsessive or compulsive questions that they can have. Placing them on a board and calendar is found to be a very successful tool to really help us to be able to redirect our patients in those manners. So the European Huntington's Disease Network really gave a consensus in 2018 and some guidelines I kind of want to review with us today. First is that of agitation, really identifying and treating the comorbid medical conditions that can precipitate some of those acute agitated moments. And then as a preventative strategy, really promptly treating irritability, not just watching it and progressing and, well, we'll just keep monitoring it, but really ensuring that we're treating that promptly, and any other coexisting psychiatric symptoms and sleep disturbances when it comes to Huntington's disease is a very, very key strategy that we should remember. And then outside of that prompt treatment, really modifying some of those environmental factors that may be contributing to agitation. So assessing the patient, community, and even environment is a key factor in our guidelines. That of anxiety, we should treat coexisting psychiatric symptoms or the comorbid medical conditions that can modify those environmental factors that's contributing and drawing and exacerbating some of their anxiety. Next is that of apathy. We should differentiate apathy from impaired ability to perform motor or cognitive skills. And this takes time and really taking true assessment. We should consider reducing the dosing of some of the medications, and then treating any coexisting depression that may be contributing to what's perceived to be apathy. That of psychosis, we should identify and treat the comorbid medical conditions that's worsening or causing for the acute onset of the psychiatric or psychotic symptoms. And then again, treating any of those coexisting psychiatric symptoms and modifying any external environmental factors. Then lastly is that of the sleep disorders, we should really treat potential contributing factors to the sleep disturbance in Huntington's disease, and assessing and adjusting dosing schedules of drugs that may be contributing to any of the sleep disturbances that our patients are experiencing. Now, moving along into the depression in Huntington's disease, we've mentioned prior that the symptoms of depression can really manifest years prior to the motor onset, and really recognizing those two main peaks. There's a peak around the time of the motor manifestation, and then that second peak around the time of loss of independence. We've also shared about the compoundedness by loss of self, friends, and ability to work. But when we get into the treatment, these first two bullet points, Dr. Sung is really going to help us appreciate when we go over some of the pharmacologic treatments. But I want to take a moment to talk about the psychotherapy and counseling in the United States. We do have a free telehealth counseling service with psychotherapists and counselors who specialize in Huntington's disease that is able to assist families and patients to get through and to manage their symptoms of depression. Now, I mentioned that we do have some issues with learning and memory, so I'm going to spend some time going through that. But there's an impaired learning of new information, and in their impairment to recall some of that stored information. And then their processing, there's a slower cognitive processing time, which leads to their difficulty in organizing information, which in my experience also worsens their symptoms of depression. And we have some studies that show that in Huntington's disease patients can recall information in a recognition format. So understanding the explicit versus the implicit memory. The explicit memory is that of names, dates, words, and then that implicit portion is how to ride a bike, how to walk, how to eat, how to drive. Huntington's disease patients have relatively more problems on the implicit side, so that unconscious memory. So some of their tasks that require implicit memory take more concentration and effort, and they're more prone to having errors. So ensuring that our families realize the difference between the explicit, implicit memory problems that our patients can experience. But some of the tips is really asking questions, giving multiple choice options. So instead of saying things like, well, what time did they say they're coming? You could try using questions like, did they say they're coming over at 10 or 11 a.m.? We can help families realize and patients to really minimize some of the distractions for implicit memory tasks. So have conversations about driving early, and then knowing that concentration is required for implicit memory tasks can then also cause fatigue and irritability. So again, I'm helping in the tips and some of those strategies for families that they need to be flexible, allow more time to complete tasks, and then choosing those battles, knowing that the irritability can be more directed at their inability to complete the task than at the caregiver themselves. Some tips for perceptual problems. One is that of time perception. So using frequent, gentle reminders to keep on schedule, then allow extra time for tasks. So when planning the day, we should do that. And then really avoiding the time pressures when possible. When it comes to spatial perception, keeping pathways clear. Dr. Sung showed us, and we really appreciated, even in the gentleman that had to walk that straight line, that we should work to keep pathways clear. Pad furniture with sharp corners to aid in any falls or injury to our patients. And then really recognizing the unawareness that our patients can have, allowing talking about challenges without having to acknowledge disease, and keeping focus on achieving small goals, and then accepting that full insight and acceptance of Huntington's disease may not be achievable for every one of our patients that we have. Now, when it comes to some of the executive function problems, attention is one of those key elements. So recognizing that our patients can be easily distracted, difficulty with multitasking. So some of those tips that we can use is reduce distractions of TV, phone, computers, and then really helping them to focus on doing one thing at a time and then moving on to the next area. Next is that of planning and organization. So patients can have difficulty with sequencing, prioritizing. Patients can feel they just can't get things done. So some of those tips is really providing a consistent schedule, having a routine, central location for posting that daily schedule, to-do lists, break things into simple tasks, and trying to limit tasks to ones that can be done without constant guidance is key. Then we can have issues with lack of initiation. Because of their concern, they're just difficult to manage starting and then maintaining desired behaviors. So one of those is external initiation, not specifically the caregiver, but done by the caregiver, but done regularly on a routine, but external initiation with family and the caregivers. And then that is of perseveration. Really, they're getting stuck on certain thoughts and ideas, that broken record thinking, going over and over and over and over, really helping them to, for a tip, to lay things out on a schedule, write out a meal calendar, and then using that gentle redirection is key as well. When it comes to impulsivity, we've talked through this, that lack of filter, acting without thinking. Some tips is try to avoid reacting emotionally, really remaining calm, and know that it is the HD talking, not your loved one. So recognize HD and who your loved one is, and really helping families not get emotional through some of their lack of filters. And then persons with Huntington's disease often, again, are remorseful after that event. So accept the apology, try not to dwell on it, because then you recognize what Huntington's disease is and who your loved one is. And then seeking medical help if severe, endangered, or unlawful, and ensuring that our patients and families are safe. So we're getting ready to allow for Dr. Sung to go over a few of our pharmacologic treatments, but I want to talk in regards to the treatment of cognitive symptoms of Huntington's disease. So prior to initiating therapy, our patients should really have a formal neuropsychological evaluation. And through that, we're going to kind of progress and track with screening tools and validated testing. So some of those treatment and interventions is that of neuroactive medications should be started at very low doses and then gradually titrating up. We can use off-label use of Alzheimer's disease medication that could be considered, and then really ensuring that our patients have good sleep hygiene practices should also be advised of our patients.
Next, I'll pick up with talking specifically about the pharmacologic treatments that are available for many of these symptoms, just kind of picking up from what the general guidelines were on the last slide, and going in with a little bit more specificity. So as we alluded to in a previous slide, depression, as far as the management, I think we all know how to use SSRIs. They are first line in treatment of depression generally. But just to say that specifically in HD, we tend to, of the SSRIs, use the non-stimulating ones first line, so citalopram, sertraline. And the reason why we use the non-stimulating SSRIs first line is that anxiety, aggression, irritability are often common in HD, as Mr. Williams just discussed. And so if we use the stimulating SSRIs, sometimes it can make those things worse. Often we avoid paroxetine and fluoxetine, not that they can't be used in HD, but because those two SSRIs are the ones that are heavily metabolized by CYP2D6, and the VMAT2 inhibitors that we'll use and we'll talk about in the next talk about managing motor symptoms, they're commonly used in managing motor symptoms in HD. So if you're anticipating that, maybe you want to avoid paroxetine and fluoxetine to avoid those potential interactions. And then we frequently do augment with atypicals that have indications in depression, such as aripiprazole. And there are others as well. As far as anxiety, as above, as I just mentioned, we generally avoid the stimulating antidepressants. I don't use very much bupropion in HD for this reason. And we can use sedatives if they're unresponsive to other options, but generally we want to avoid too much use of sedatives. And as far as the other things, as Mr. Williams hinted at, like there's these tips and tricks to manage irritability, aggression, impulsivity, OCD, things like that. But sometimes they reach the point that pharmacologic treatment is necessary. It's just a reality, and we have to do that to protect the safety of the patient, the family. And what I found is that often these symptoms are very responsive to medications, even very low doses. The general mantra is starting with an SSRI, and then moving to a mood stabilizer, and then antipsychotics if their behaviors are explosive or violent and we're worried about safety. But just as an anecdote, I had a patient who had an impulse control problem that involved him exposing himself to the mail lady, which was very stigmatizing and led to legal troubles, all those things. And I gave him a tiny dose of Depakote ER once a day at bedtime, and that impulse went away completely. So just to say, like 125, it went away. So that's pretty nice. Memory loss, executive dysfunction, as we talked about, the cholinesterase inhibitors in that previous slide can be used, but they've all been studied and don't have statistical benefit, but there is some off-label use with some anecdotal successes. And then lastly, other treatment considerations, we really want to treat comorbid conditions such as substance abuse. They can cause a lot of problems. And the mental health care access is challenging across our entire country. We know that. Mr. Williams lives that every day. Sure, it keeps him busy because there's nobody else, right? There's not enough mental health providers. We all know that. But I did want to reemphasize what Mr. Williams already introduced, this free telehealth psychotherapy and counseling. It's available for all persons affected by HD. Each person can have their own free counseling if you sign up there. So the patient, the caregiver, the son who's at risk, every individual person is eligible. And all you have to say is you're affected by HD. You don't even necessarily have to have it or be at risk for it yourself. And these therapists have all been trained on HD. What I tell my patients when I tell them, like, the benefits of this program are, one, that it's free, and two, they're going to be matched with a therapist who's been trained on HD. So they don't have to spend the first few sessions of their psychotherapy explaining to them what HD is, right? Whereas other therapists in the private sector may not be that familiar with HD. So I think those are two huge advantages. And then, as we've already hinted at, multidisciplinary care is important. And so I'll turn it back over to Mr. Williams to close us out to talk about multidisciplinary care and take us through our key learning points.
Thank you, Dr. Sung. Yes, when we really understand the importance of having a multidisciplinary approach to caring for patients with Huntington's disease, we should remember that it's not a siloed condition where it's just treated by a neurologist or just treated by a psychiatrist. We really need to utilize a team approach. So first is that of a neuropsychologist to help document the baseline, quantify some of those cognitive declines. We need to have next the psychologist to help with counseling of both the patient and the caregiver. We need social workers to help with disability, and then the supportive care in all aspects of the condition. And then we have over 60 centers of excellence programs, which is modeled for multidisciplinary care, over 60 across the United States. And when we still have patients who have to either travel from long distance or maybe have poor insurance coverage, it may be only the opportunity to have them care from those disciplines. But I'll say, even if you're in a center of excellence, or if there's one nearby, or if not, and the patient might be in a facility, I still want us to walk away from here remembering that we still need a team-based approach to caring. And in the long-term care space, sometimes my patient isn't able to get to the center of excellence that's in our community because of the condition. So we need to have, we create our own team-based care in that long-term care space, and utilize meetings and discussing the patient together and working as a team, from the therapist who's doing PT to the speech and the nursing team and the leadership on the nursing side and the medical team, and having the patient's caregiver present in the meetings and really using that team-based approach. And then we also have the centers of excellence around the country that really help to model that multidisciplinary care. Now, going into our key learning points. One, remember that depression may occur prior to the motor symptoms in Huntington's disease, and in combination with impulsivity, increases that risk of suicide. Next, social support and crisis prevention measures are important ways to manage some of those behavioral symptoms that we discussed. Thirdly, we should remember and understand that implicit memory tasks are more challenging for Huntington's disease patients, and we should make sure that we're helping to manage some of those cognitive problems in Huntington's disease. Dr. Sung helped us with those pharmacologic interventions for cognitive problems, but remember that they're more limited, but really that multiple symptomatic therapies do exist for behavioral symptoms in Huntington's disease. And then lastly, the non-motor symptoms in Huntington's disease are best managed with that multidisciplinary approach to care. All right, we're going to move now to questions and answers. All right, well, welcome back. We are in our Q&A for part 2, and we'll go ahead and jump into the questions that have been asked thus far. So the first question is, why is impulsivity high? Is there any neurobiological basis? Because apart from impulsivity, other neurodegenerative disorders also have functional loss and being lonely.
Yeah, I think the answer is we don't know exactly, but I think it's similar to why when people ask why, for a somatic mutation that's expressed in every cell of the body, why is the brain more affected than other parts of the body? And then within the brain, since it's in every neuron in the brain, why is the deep part of the brain called the striatum more affected than other parts of the brain? There's theories on why those kinds of things, maybe certain cells are more susceptible to the kinds of problems that are caused by the mutated Huntington protein. But ultimately, the result is that the atrophy that we get in the brain is not uniform throughout the brain. There's definitely more atrophy in the deep structures like the striatum, which is the caudate and the putamen. And we think that the striatum, while it is part of the basal ganglia, which is classically implicated in movement, the striatum has a lot of projections to the frontal lobe. And probably when you have this disproportionate striatal atrophy, and then you lose these projections to the frontal lobe is what we need to be. I think of it as our giant filter, our behavioral filter. And when you lose that, then you get the irritability, impulsivity, perseveration kinds of things that Kevin just talked about, or that we kind of just talked about in the talk. So I think that's why, more so than other diseases, more so than other neurodegenerative diseases, this striatal frontal lobe projection is lost more, and therefore you get more of this impulsivity. If you have lived with Huntington's disease or been around a lot of Huntington's patients, this impulse control is definitely a significant problem.
And in managing that, patients that we have, really taking that team approach, educating early the family and caregivers. If they're in long-term care facilities that I'm treating, ensuring that our staff is aware of these things and recognizing when it's in its lower state, and then ensuring that we're being aware and made alert to start recognizing those things to avoid having those ups and downs and the impulsivity and some of the aggression that sometimes can take place as well.
Yeah, and we talk a lot about choose your battles, but I think sometimes it's knowing that that's part of the disease, right? They're not just being obstinate or ornery, or they're not, it's not necessarily anything that you did or as a caregiver did to set them off. It's part of the disease. And usually when we talk about these things in clinic, we get a lot of head nods, like, oh, yeah. And so the first step in combating this, like we talked about, is the understanding of it. And then you use that in strategies to approach it.
We have a question in regards to a clinical psychologist who has some patients with Huntington's disease. The question is how would we suggest they can obtain more training on working with HD, as well as expand the network to include specialists in assessing HD, which I think that kind of leads to some of those counseling services. So,
yeah, I think one is being here today for CME programs like this to get more training on some of these tools. There is a lot of the tips and tricks that we put in this lecture are pulled from a book called The Clinician's Guide to the Management of Huntington's Disease. That book is available for free download from the HDSA website. It's a PDF. There's great resources in there. And then the Huntington Study Group has a neuropsych consortium or subcommittee group. I forgot exactly the name of it, where a lot of clinical psychologists and neuropsychologists get together, a working group, get together and talk about some of these issues. So I think that camaraderie and how they address these issues together can be helpful. So joining with there is a good idea. And then expanding your network to include, what's the book name again? Okay, it's called The Clinician's Guide to the Management of Huntington's Disease. I will try to find, when we're reading another question, I'm going to try to find the link to it and I'll drop it in the chat, and then we can push that out to everybody. But it's a free PDF download. I want to say that's what it's called. I'm trying to see if I have it on my shelf. I think my copy is loaned out to somebody right now. But Clinician's Guide to the Management of Huntington's Disease. As far as expanding the network to include specialists in assessing HD, I think the easiest network is the Center of Excellence Network, the HDSE Center of Excellence Network. Finding the COE that's closest to you, and they can give you guides. They all have specialists there at their COE who are trained in managing or assessing HD, and they can give you tips and tricks. All the COEs are required to do professional training days and things like that. So, and then I would just peruse the HDSA. It's hdsa.org/publications. There's a lot of good resources on there that are free for download. Okay.
I just pushed it.
Okay, A Physician's Guide to the Management of Huntington's Disease. Thank you. Okay.
How do you deal with a patient who expresses a desire for assisted suicide when legal?
Ooh, I don't know that I've encountered that specific thing. I've had, it is not legal where I practice in Alabama, so I haven't encountered that specific thing, but I've encountered that attitude in kind of roundabout ways. So I'll tell you one example. I had a patient who, my fellow had seen the patient and came out and presented to me, and she said, "Oh, did you see the track marks on this patient's arm when you were in there?" And I said, "No, I didn't notice that." And so I went back in there, and he obviously had track marks from IV drug use. And so I talked to him about it. And once I asked him about it, he was very upfront about it. And he was like, "Yeah, I do it. And I know it's bad." And his attitude was very much like, this horrible disease is going to kill me. And doing drugs may kill me a little bit faster, but I've already lost all my family members to this horrible disease, and I'm going to lose myself to this disease. So if this gives me even momentary, brief happiness is what he called it, then what's to stop me from that? And that's that kind of self-destructive kind of behavior. That's not, a similar kind of attitude to the people that seek assisted suicide. And then I've also had patients who, when we talk about all this research, right, research for a cure or these disease-modifying therapies, when we talk about these genetic interventions to slow the progression of the disease that we're working on so heavily right now, where the patients say, "Well, what's the point? I'm already in an advanced stage of disease. Why would I want to even slow it down where I'm at? I should just, I actually would rather have something speed it up and just let this disease take me. I'm sick of living like this." And I think in all these kinds of things, the similarity is asking probing questions to ask, like, where is this coming from? Like, where is the idea of wanting to do this coming from? And what's at the root of that? Is there some kind of suffering or discomfort that's at the root of that we can treat on this side of life, right? And addressing that, as we talked about, in a multidisciplinary way, addressing that in a lot of ways. Like, my standard thing that I always say is that in my big clinic with a huge team is say we have a whole team and that we treat that we view as our family. And then when you have HD, which is a family disease, then your family is part of our family. And so just like I would not want one of my family members to, feel like that they needed to commit suicide due to a terrible disease, I don't want that for you either. And that we will all walk this road together, that, our family, our team is here for your family in all the ways that you need. And we'll walk right there beside you step by step throughout this whole journey. And sometimes just that feeling like they're not alone, right? Letting them know they're not alone, and they don't have to walk this journey alone, is just a big part of it, more than any pill that I can prescribe. You know what I mean? Kevin, anything you wanted to add there?
No, I was actually, you made mention of what I also share with our team is getting to the root of the statement or the feeling that the patient's having, and not taking our own assumptions and superimposing it onto the patient, but really digging into the root of that is actually the same approach that I take from a psychiatry standpoint, and then individualizing their treatment and being open to what are we going to do tomorrow, next week, and really establish some set goals in that treatment and family community. So, very similar approach. Do you find there to be any restrictions on the free counseling program that we mentioned for HD patients and families?
Yeah, so the one thing I'll say is when you get into the program, it will say in the statements when you sign up for it that it covers 8 visits per year, which is a little less than 1 per month. But I will tell you, in the history, I think this program's been going on for like 6 or 7 years. And the history of the 6 or 7 years of the program, they've never cut a patient or family member off. So they state that it covers 8 visits per year, but if you need 10, 12, 14, 16 visits per year to get the support that you or your loved one need, or that your patients and loved ones need, they won't cut it off. So, there's a big grant that's there to support this, and it's helpful. It's really invaluable. But like I always say, like all things, whether it's medication or a therapist, there's a little bit of a trial and error to it. So I encourage my patients, like, they connected me with this guy. It wasn't a fit or whatever. We'll just try again, and see if you can connect with a therapist that jives with you. But the main thing is it's free, and all the therapists should have already been trained on Huntington's disease, which is nice.
Yes. So we talked about in this session the high rate of depression and suicide in Huntington's disease. Does that affect, how much of that affects your choice of treatment for the motor symptoms like the black box warning order?
Yeah, and we'll talk about this in the next talk too, but this question kind of sets up our next talk, where we're going to talk a lot about selection of therapies for managing the motor symptoms. It certainly affects it to a degree, but my general approach to it is that I don't fear black box warnings. If we did, then we would never prescribe any antipsychotic, right? All the antipsychotics have black box warnings. All of our VMAT2 inhibitors, which are the new treatments for the treatment of HD chorea, they all have black box warnings. The black box warnings for treatments for HD motor symptoms all are relevant to depression and suicidality. And what I address with my patients, if we're starting on those drugs, is to say, well, I care about depression and suicidal thoughts, whether or not I put you on this drug for your movements. So if you have any of that, I want you to tell me, and then we will address it. Regardless of whether or not we go on this medicine for your chorea. The VMAT2 inhibitors are very effective for the treatment of chorea. So if I feel like they really need it and it will help their chorea, then I do it, even if there's still depression. And we just put safeguards in place and counsel extensively around it. But, I've had patients before who are like, I want the medicine that will fix all my symptoms and not have any side effects. And I always say, I want that too. But that is unfortunately not a world that we live in. Although hopefully you'll see at the end of the next hour, our new treatments really are better. I mean, they genuinely are superior from a side effect standpoint, and they're getting closer to what we want, which is effective treatments for the symptom that this sets out to with minimal side effects. Not perfect, but better.
Seems that we have one final question for this particular lecture. And what is the most challenging behavioral symptom to manage?
Yeah, I think the most challenging behavioral symptom by far to manage is apathy, for multiple reasons. I think one is that apathy can be very difficult to distinguish from depression, right? So, the lack of motivation thing, which is apathy, but a lot of people who are depressed, they don't have the energy to want to do their daily things too. And then the other problem is normally we treat apathetic kind of symptoms by stimulating, trying to get the system up. And stimulants in an HD population have lots of peril, right? They can drive irritability, impulsivity, chorea, all to be worse, and can sometimes cause more problems than benefit that they get. So because of that, just all in all, a difficult symptom to treat. I just had a message in my inbox today about really problematic apathy. And when it's severe, it's actually very clearly different than depression. So this patient's not depressed, but they have no motivation. They have no desire to even do basic things like bathe, clean up the house. And so there's we got this message about bug infestation problem and really foul smells and poor hygiene for one of our patients, who's not depressed, just has severe apathy, and how to get around that. And but to follow the same theme that we've been talking about this whole hour, which is that the solution does not always lie in pills. And while there are not effective pharmacologic treatments for that, there are maybe some things that we can do that are non-pharmacologic to kind of encourage. So things like creating a routine, or using home health to go in there, having other people come in the house and assess and help. Home health, physical therapy, or aid in attendance, or occupational therapy, or nursing, all those combinations of things to kind of come around the patient and support them, that can be sometimes helpful as well.
And just to add on to that, I think with that apathy that patients have, recognizing to educate the caregivers that we're really running a marathon. Mm-hmm. So we often want to go to that pill to resolve it quickly, but establishing therapy, finding the right connection, not giving up on the selection of the therapist, the community support, and then maintaining that routine in our patients and really establishing a continuation of our services outside of just medications really is needed to support our patients with managing behaviors, which presents itself in a variety of ways, but we're often classifying it as just depression. So give a medication for the depression. And really that multi-team, multi-specialty approach helps to manage those behaviorals and non-motor symptoms that our patients have. So agree.
I mean, if you think about, like, if you've treated schizophrenia, right? I mean, we have much better pharmacologic treatments for the positive symptoms, like the hallucinations, delusions, psychosis, psychotic symptoms, than we have for the negative symptoms, right? Which are harder. The activating from the negative symptoms is just harder without getting a lot of side effects. We can block a lot of things, but activating a lot of things in the brain, hard to do in other diseases as well. And that applies to some of these symptoms of HD, these behavioral symptoms. So hopefully you can take some of the tricks that we offered you, tips and tricks that we offered you in this talk, and take those forward, because they're often more effective than pills.
Well, I think we've come to the end of our questions for this section. Any
What is the incidence of HD, and is it localized? So we do have good assessments of prevalence. Incidence of HD is hard because, technically you have onset. Where do we draw the line, right? Like you're born with the mutation. Only a very small number of people choose to be genetically tested, but we do have relative estimates of prevalence. And in the Western Hemisphere, the prevalence of HD is estimated at about 5 to 10 per 100,000. But interesting, if you look at that, the prevalence of HD, which is the number of people living in the United States with HD at any one time, at 5 to 10 per 100,000, is actually pretty similar to the number of people living in the United States with ALS at the same time. And yes, HD is a rare disease, but ALS, not just because of the ice bucket challenge, but because of baseball players like Lou Gehrig and football players and things like that who have had it, has a much bigger profile than Huntington's disease. But the difference is that since the lifespan of an ALS patient is much shorter, right? Life expectancy with ALS is about 3 to 5 years, whereas life expectancy with HD is about 15 to 20 years. So that means that any one time, there's a lot of turnover in the ALS population, but at any one time, there's about the same number of Americans living with ALS as there are living with Huntington's disease. But that also means that if you are a doctor or a nurse practitioner or a provider of some level in the United States, prevalence is the likelihood that a patient with that disease will walk into your office, right? So the prevalence, the likelihood that a person with Huntington's disease will come across your doorstep is just as likely as the prevalence that someone with ALS will come across your doorstep. So just really emphasizes that this is an under-recognized disease, and really there's things that we can do to help, and we should be doing them.
Well, we have come to the end of part 2. We'll take another brief break and jump back into part 3.